Good morning, and thanks for the opportunity to provide an update on acute mechanical circulatory support. The field of acute mechanical support is rapidly evolving, and participation in randomized controlled trials and registries is required to generate the high-quality evidence needed to advance the field. However, randomized controlled trials requires active recruitment and willingness to randomize patients. I think this has been an issue that has hampered us in terms of advancing the field of mechanical support because of this question of randomization. So I thought I would talk about some of the emerging randomized controlled trials that are in the space. As you're all familiar with, the PROTECT high-risk PCI program began in 2006 with the PROTECT-1 FDA pilot study. This was followed by PROTECT-2 in 2007, and most recently, the FDA post-approval study completed in 2019. This is the PROTECT-3 analysis. And what we've learned over the years is that with increasing use of best practices, there's been a significant reduction in composite major adverse cardiac and cerebrovascular events at 90 days with the most recent data set compared to the original data set using intra-aortic balloon pump. Now, based on all of these learnings, the PROTECT-4 study will now use high-risk PCI with and without Impella support. And the question is, would you randomize your patient who has a low EF, who's undergoing high-risk PCI, to having no support or to requiring Impella support? And I think that's where all of us need to participate in these RCTs to generate that much needed data set. Now, another high-risk PCI trial is the SHIELD-2 randomized controlled trial. This is utilizing the HeartMate PHP device and comparing it to the Impella CP for patients who with low EF undergoing high-risk coronary intervention. Now, the technology here is a self-expanding cannula that goes from a 14 French insertion profile to a 24 French transvalvular profile sitting across the aortic valve. And what we've seen in the roll-in analysis is that this pump can achieve flows over 5 liters per minute. But this is another study that requires active recruitment and randomization in order to advance the field. Another trial in the setting of high-risk PCI is the STEMI door-to-unload randomized controlled trial. Now, this is a paradigm shift in cardioprotection for anterior STEMI and is based on recent data showing that unloading reduces myocardial ischemia before reperfusion. What you're seeing here are two angiograms. This is a proximal LAD thrombotic occlusion in a patient in the STEMI-DTU pilot study who had the Impella inserted first. 30 minutes of conditioning with the pump went by, and then the coronary epicardial vessel was revascularized. Now, in a recent sub-analysis of the STEMI-DTU pilot study, we see that the duration of unloading is inversely associated with infarct size, suggesting that during the period of unloading, before epicardial reperfusion, the pump is already beginning to mitigate and reduce ischemic injury. Now, this was studied in a preclinical study where two proteins that are known to be very sensitive to hypoxia were measured in animals that underwent LAD occlusion without a pump versus with a transvalvular pump, but did not have any reperfusion. And what we can see here is that with LAD occlusion, there's a significant increase in these two proteins, HIF1 alpha and PHD2, but with activation of a transvalvular pump, these levels normalize, suggesting that even before reperfusion, there's already a reduction in the amount of myocardial ischemia. Now, based on some of these observations, the STEMI-DTU pivotal trial is now underway. This is now actively enrolling patients and is comparing door to unload with the Impella CP for 30 minutes prior to reperfusion compared to door to balloon. The primary endpoint is infarct size, but the key secondary effectiveness endpoints are looking at heart failure outcomes such as cardiogenic shock, heart failure hospitalization, as well as the need for ICD or CRT placement. Another critically important trial that requires active recruitment and randomization and participation from the interventional community. Now, I'm going to shift gears and talk a little bit about cardiogenic shock. The recent publication of the SCAI stages consensus opinion has now created a platform for defining shock severity. There have been several papers that have now validated the association between these SCAI stages and in-hospital mortality. This is the Genser analysis from the Mayo Clinic. This is the Shraga analysis from the European experience, again using slightly different definitions of the SCAI stages, but nonetheless showing a association with in-hospital mortality. Now, more recently, we have applied the SCAI stages to the Cardiogenic Shock Working Group registry and gained some insight into some of the mechanisms of cardiogenic shock that we might not have known before. One of the key learnings that we took away from our analysis is that a substantial number of patients in cardiogenic shock have biventricular congestion, which means that they have an elevated right atrial as well as wedge pressure, suggesting that congestion is critical, as well as hemodynamic guidance is important for understanding and managing our patients. What we also saw was that with increasing SCAI stage severity, there was also an increasing burden of patients with biventricular congestion. Now, the reason why this is important is that we are also seeing that biventricular support use is also increasing with SCAI stages. And if you look at device utilization from the Cardiogenic Shock Real-World Experience Registry, we can see that by the time you get to SCAI stage D and by the time you get to SCAI stage E, you're beginning to use a lot more biventricular support for these patients. And the question is, how do we take all of these learnings and apply them into a randomized trial or develop algorithms for patient management? And we've seen over the years that there have been a number of negative randomized controlled trials in the shock space, going all the way back to the negative RCT of the shock trial in 1999. This was followed by several negative RCTs, which haven't really moved the dial in terms of survival. But what we have seen more recently is that prospective registries that employ hemodynamically driven algorithms are being associated with increased survival. Now, more recently, the RECOVER-3 analysis looked at pre-PMA versus post-PMA outcomes for patients before approval for Impella for cardiogenic shock, and we are seeing a reduction in in-hospital mortality. So collectively, the data that we're seeing is that we have to apply best practices into an RCT, and this is the RECOVER-4 trial that's now in development, which will implement things such as early support, pre-PCI support, hemodynamic guidance, and escalation strategy, as well as vascular safety approaches to optimize patient outcomes in cardiogenic shock. And this is another study that requires randomization. But I think it's very important to understand that to advance the field, we have to randomize these patients in cardiogenic shock. A patient coming in with STEMI who has SCAI stage C or D cardiogenic shock referred for primary PCI, we have to be able to say that we are going to randomize this patient to drug therapy, balloon pump, or Impella. And the question is, would you be willing to do that? And would you be willing to do that with avoiding crossover between the groups? Because if we do not randomize, we will not advance patient care. Now, this is a list of randomized controlled trials that are actively ongoing in the space of mechanical support and cardiogenic shock, and you can see that a substantial number of these trials actually involve ECMO. Now, I think it's really important to understand that ECMO is becoming a commonly used tool and technology in the cath lab. We are seeing an 11-fold increase in the use of VA ECMO for acute myocardial infarction in the United States. But this is still associated with in-hospital mortality that ranges between 40 to 60%, depending on the study you're looking at. We're also seeing increasing concomitant PCI or other mechanical support with VA ECMO. And in fact, same-day VA ECMO plus additional mechanical support is actually quite common. Now, the reason why this becomes important is that poor ECMO outcomes are driven in large part by complications. And these are the various complications that are listed here on the right, and you can also see some of the key references that look at some of the contemporary data, especially looking at vascular injury, stroke, a kidney injury, LV distension, as well as thrombus formation. But I think this recent analysis also highlights that despite the fact that we're increasing the use of ECMO, we are seeing that this is actually associated with an increasing rate of ECMO-associated complications. And as ECMO starts to come out of the operating room into the cath lab, I think it's important for all of us as interventionalists to become familiar with the technology and to come up with strategies to mitigate some of this risk. You're familiar with data showing that Impella is associated with better survival than VA ECMO alone. However, in reality, when we look at Impella implementation in the cath lab, this is a substantial area for risk of bleeding, vascular complications, and other complications for the patient. And I think this is where we have to start innovating. Some of those innovations we'll talk about here at the CVI meeting about how we can improve our approach to ECMO in the cath lab. And I think this is going to become a primary focus for acute mechanical support over the next decade, is how do we mitigate vascular complications and other complications associated with the technologies. We've seen from a recent analysis that the prevalence of acute limb ischemia is actually increased as you go from balloon pump to PVAD to ECMO, and that untreated acute limb ischemia is associated with almost 100% in-hospital mortality. So identifying the problem, preventing the problem, and also managing the problem, I think are going to become key focuses going forward. And there are a number of protection strategies that have evolved over the last 5 years to try to reduce the risk of vascular complications with acute MCS. Now, the field is very exciting. There's a lot of innovation coming out in mechanical support. We talked about the HeartMate PHP. There's also the Impella ECP, which is Impella's version of the expandable pump that is now undergoing investigation. The Impella 5.5 pump is now in clinical practice, as well as other technologies that are emerging, such as the IVAC 2L. And we are also seeing a group of other devices that are emerging that are targeting other aspects such as afterload and preload in the setting of heart failure and cardiogenic shock. So with that, thanks very much for your attention, and I'm happy to answer any questions at this time.